but very grateful that you're able to join us today and that this session is able to go ahead. I'm Catherine McKinnell. I'm chair of the Petitions Committee, and we're very grateful to be having this session because it comes out of a huge level of public interest, clearly, in coronavirus and the government's response to it and the public's response to it as well. And we've had 50 e-petitions tabled on a whole variety of aspects in relation to this issue, and they're signed by over 2 million people. So the public interest in being able to present not those petitions themselves, because we are not able to hold debates in Parliament, but to raise the concerns that are highlighted by those petitions, and also in the public engagement that we have undertaken since those petitions have been tabled. We have had over 60,000 questions submitted by members of the public. We're not going to ask you 60,000 questions, but we are going to try and collate all the issues that have been raised into hopefully questions that you can answer today to give clarity and reassurance to members of the public on the concerns that have been raised. So this is obviously a bit of a first for our committee and many committees holding it in this forum. It's clearly got to be the best way that we can get answers for the public and enable the public to hear directly from you through whilst not having to travel and being able to do it from our homes or our offices in a socially distanced way. So thank you very much, everybody, for partaking in this. So my first question is actually in relation to the advice that's been issued by the government to date on what people do need to be doing to protect themselves and others. And the advice which, although there are some elements that are absolutely clear and have been clear from the start, there are other aspects of the advice that are changing on a daily basis, which has presented challenges for many people who are still uncertain about what they should be doing. First of all, do you accept that there has been a lack of clarity for the public on some of the guidance that's been issued? And what would you say now that people should be doing to limit the risk of infection to themselves and others? Shall I come to you first, Jenny? Is it okay if I call you Jenny, or do you prefer your full title?
No, that's absolutely fine, thank you. And obviously I'm getting used to this communication, so can I just check that you can hear me okay before I start?
Yes, I can hear you really well.
Excellent. So I'll start off, but then obviously if you want to, I'm sure if you want to ask me supplementary questions, I'll start at a high level and then you can dive into whatever you'd like to. I think the important right at the start, as we all know, and simply because of the way we're communicating now, this is an unprecedented event. Certainly in most people's lifetimes now, we have not had a pandemic like this in the UK, and we have different communication tools at our fingertips now, which is excellent. But that also presents some challenges in terms of pace and the flow of information, much of which is not controlled by government at all. And I think so these are common ways of doing things. I also think we have tried to exploit all those different channels in communicating with the public. And my final as a starter is, as a public health doctor in training, thought that if you have a public health incident, that can be either there is a public health issue, or it could be a public health incident because the population thinks there is an issue, and both of those apply in these circumstances. So the behavioural elements are really, really important, and they are important in managing the risk of the incident itself, because if people misunderstand or become anxious at different points in the incident response, that in itself can have a negative health. So I think what we have tried to do with communication to, through a strategy, is explain the outbreak to the population as best we can, try and keep confidence in the government's and the NHS response to that incident, and clearly, fundamentally, minimise the risk of infection in the population, and therefore the subsequent the health impacts and the possible in the population as we go forward. So we started off very early on with a very basic, what I would call infrastructural message. Now, to the public, washing your hands frequently, I think has perhaps seemed a very simple message, although people, I think, are increasingly understanding that this is a building block for building the resilience in the population we need. So we started off with a marketing campaign which involved behavioural scientists trying to encourage people to minimise the risk of infection, both through hand washing predominantly and through the cough, catch it, bin it, kill it variation of the like. That campaign was launched in what was called the campaign phase, right at the start of February, I think the 2nd of February, and it coincided with isolation of people returning from Wuhan, when we were trying to very much ensure that we, for as long as we could contain people. So being included what individuals could do on a general basis, but equally what individual returning travellers could and should do as they came back from other countries. So that was effectively our contain phase. Then as the transmission increased through the community, we to tell people to stay at home if they've had illness, and also try to safety in our systems by directing people not to go to their GPs and not to go to hospitals, but use online 111 or telephone systems for that. And then we continue the watching campaign. As cases rise and we move into the delay phase, we have very clearly set out a coronavirus action plan, and that also has been communicated. And although I think from a public perspective that may be seen more as a government issue, nevertheless it's designed to contribute to the consistent messaging and the public of the plan we have to follow through based on science, and then responding to the changes in the epidemic as we go through. Just on channels of communication, we've used lots of those, which I'm happy to go into, but radio, press, I know the public now will be very aware of the black fluorescent campaign, which started with the wash your hands message and has now translated through to don't go out, only go for essential exercise or essential and we tried to keep through a number of different roles, through platforms and key influencers, so direct contact, for example, working with Department for Culture and Media, with various groups, organisations, all of these links out to the public, whether they be direct or through other parties. So I'll probably pause there and then you can ask some questions.
I mean, one of the aspects of the government's advice that a number of petitioners have got in touch to convey concerns about is that initially the government's advice was that they were, well, I don't know whether the word comfortable, but they were not concerned about large numbers of the public contracting the virus on the basis that that was actually required in order to build immunity. And then now clearly the advice has changed and we want to try and minimise the spread of the virus. Can you just clarify how that has changed and why that changed?
So I don't think it has changed, and I think it's really important. I recognise that different people, there's a message and there's a giving of a message and a receiving of a message, and I recognise that some people have perceived information in one way, but for absolute clarity, the herd immunity messaging which people heard. This is not a government approach, strategy plan in any way whatsoever. It never has been forward that way. Herd immunity is a natural bias. If you have a population, as we have currently in the world, where people have not seen this infection before, we quite know a few people with antibodies. Do know, go forward and more people become infected, we will have resilience. But that is the biology of the outbreak. It is nothing to do with the plan, and the government has always made it clear that we would try to minimise the number of infections, but particularly minimise fatalities associated, the number of deaths with this incident. If you have a pandemic where the transmission, unlike something, for example, like Ebola, which is a very direct contact transmission, if you have a pandemic of a respiratory infection, it's not a change of policy. It is almost a recognised inevitability that we will have a large number of cases, which is why we have always had a very clear plan of contain, delay, and the way sitting behind all research.
Okay, and I mean, in terms of how the government is able to track the spread of the virus, the World Health Organization has given a very clear message: test, test, test. Countries such as South Korea and Singapore have managed to flatten their curve, got ahead of the spread of the virus through extensive contact tracing and isolation. The UK test rates do not compare favourably with the vast majority of other European countries, and in particular the countries that are managing to flatten the incidence of the virus. Why do you think this is, and what do we need to do to get better at testing?
So it's really, really important to understand what different countries are doing. There's a preamble for me here, which is we will not be able to be clear what interventions have been successful in the UK or even in places like Singapore or South Korea until a long way ahead. And the reason for that is that the way different countries are reporting their testing and their reporting cases is very different. So, for example, in China, the early cases that were reported, and probably now the case definition involved you to have had, for example, at the start. So clearly the case numbers are very different to if you're reporting mild symptoms. And equally...
So, so are you confident that we are doing enough?
I'm very confident we are. What I'm trying to get at, there is a plan. And if you look at countries, so if we actually go to China data today, where people have been reporting early success, we need to be very cautious. I think, I don't have the data in front of me, but I think reported another 78 cases. Now, that may be inconsequential or not. The point is that the plan in the UK has always been to manage the peak of the curve, to push it downward, so we can support all of the people who need care through our hospitals. We do not want to push it too far forward into the next winter, and we definitely don't want to, if we can avoid it, happen second. And where countries, the modelling set showed, first of all, where countries suppress very hard and without clear plans to do it, there was a very high peak happening when we perhaps did all of our. So I'm very content that we have. You raised the question about testing. There is a huge amount of work on testing. So within about 3 or 4 weeks, we will have 5,000 tests per day capacity within the NHS. So this is for the people who are needing care, and that will be for our frontline health and care workers. But simultaneously to that, there is a programme currently being tested to separately outside, so it's not interfering with the work of the NHS, do hundreds of thousands of tests in course for, as a starting point, again, our health and workers, but equally then moving on and rolling out to the public. And that's an advanced form, but clearly they have to be good tests. They have to be sensitive and so we should not be rolling them out until they are fully evaluated.
So without extensive testing, which, as you say, we can't compare to other countries, so how are we measuring our success at controlling the virus?
So we won't know just yet. We need to, the reason the Prime Minister said earlier in the week that we will review in 3 weeks is because we will start hopefully to see a change in the shape of our epidemic curve. If people have complied with the rules properly, we will see that going in about 2 to 3 weeks. So that is one way we will do it. But actually, right beside the testing, we have a genomics program setting off as well, and we will have antibody testing. So it's quite complex. There's the have I got it now test, there's the have I had it test, and then there's a genomic investigation to see what we can see about the movement, if you like, of the different types of the virus around the country. Both of those latter two, the had it and the genomics, will give us much stronger information about the spread through the population, and will give us an indication on a representative proportion of the population, how many of them may have had it without having many symptoms. Give us really good evidence then to say how we manage the later part of the epidemic in the UK, and what different interventions we put in, or whether we can take some off.
Okay, I mean, but can you understand that the public might find that quite an anxious time, waiting 3 weeks to know whether we've done enough to control the virus, but also in the meantime, watching the capacity of our NHS, whether it's enough, and in terms of the testing, whether we're doing enough to test our NHS staff so that they are not spreading the virus, and also they know that they can go to work, because even if they might have some symptoms which are gone in 1 or 2 days of a common flu, they can go back to work and do their job and support those people who are suffering from the virus. What's the government doing to make all NHS are getting tested?
Yeah, so I absolutely support that. We recognise it, and I mean, just going straight back, there is a plan that's underlying all of the actions. It is scientific driven, and the key people say right at the front of this, and it's not just the health and care workers. So, for example, somebody working in laundry in the hospital is a key person for continuing the care of people who will be coming through. The army are now helping for testing, logistics, PPE distribution, and all of those sorts of things. So these key workers are the ones that we do want to test, also to ensure that the most vulnerable, those most at risk of the disease, have care workers attending them who have disease. We know they will be safe too. So in terms of that testing, ramping up to the 20,000 within the NHS, will start support, and there is some testing going now, the layers of healthcare colleagues who are contributing, but equally the end-to-end service outside of hospital currently being tested and evaluated is the one which is picking mostly to support our health and care staff. It's in the public's interest, the healthcare workers, the government's interest not to do this. We all recognise it is the most important next.
Okay, so I'm going to bring in Teresa Villiers now, who wants to ask about public transport and other issues as well. So Teresa.
Yes, thank you for letting me come in here. I think there is some confusion about the advice relating to public transport and people going to work. Now, my understanding of the public health advice and the rules of social distancing is that for individuals who cannot do their job at home, they are permitted to go to their place of work to do their job, so long as they take appropriate steps at that workplace to observe a 2-metre distance as much as possible between themselves and other people, whether they're colleagues or customers. But on London ground, the message coming across the public address system is that you should not be using you should not be on the public transport system unless you are a key worker doing a job which is relevant to supporting people through this crisis. So it would be really good to get your thoughts what the public health advice really is about people working where they can't do it from home, how they get to work.
So, I'm obviously a medical advisor, and I'm going to provide the public health element for that, and the advice that we have given to the government. So, but there is in all of this, if I go right back to the start, a really broad public health and population assessment, if you like, because asking people to stay in their homes for protracted periods of time is a very balanced and new requirement. We definitely need to reduce our social interactions, and that is the basis of the social distancing policy. But equally, we don't want to create unsafe environments by doing that, where the risk for an individual or a family unit may be greater than the total population risk from coronavirus. So these are perhaps I think they are clear messages, and I'll come on to them, but I think we just need to keep at the back of our mind there will be some circumstances which have been highlighted in the guidance. So, for example, a very vulnerable, highly at risk individual who is dependent on care might do better theoretically from having no interactions, but actually that individual almost certainly might have 4 or 5 different carers with whom they are very familiar, coming into their home on a regular basis, and that is their lifeline for survival. So we need to keep a really clear balance on this. But your point about work is, so we have said people should work from home where they can, and it's surprising as we are demonstrating just how much work you can do in a different way from a home environment. So that's the first one. If you can't work from home, then you can go to work, but perhaps adapt how you work or what you're doing. So it may be that different roles can be changed, or I am currently in a work environment as a key worker, but I also know that there is a lot of space created because many of my colleagues are working from home, so I can social distance very successfully in the work environment. And then there will be other people who, as you've noted, there are key workers who need to be out working. I know there has been a lot of noise about construction workers, and I'm not intending on a professional basis to comment on the sort of political angle for that. On the scientific perspective, there are 2 points that are probably relevant. People working outdoors where they can space themselves effectively. The virus doesn't survive as well outdoors as it might do on a hard internal surface, so that risk element is reduced. And then the issue about transport is absolutely ideally, you'll have seen the things, you know, wash your hands, because you may pick it up if somebody's coughed and sneezed and then wiped it on any hard surface. It might be at work, it might be on transport. That could be a potential problem, but the mitigation there is to keep washing your hands. But equally, actually, the modelling does not suggest, and we have done this all very much on scientific modelling and taken the biggest interventions that are going to have the most impact for us. The transport one is not actually a significant intervention. If it had been, if it was the one at the top of the list, that's the one that we would have followed from the science to start with. But it doesn't actually seem to deliver much impact. The one that does really deliver is reducing our total overall social interaction. So somebody who's going to work may still actually manage to reduce very significantly their social interactions now, because they are not going to the pub, they're not going out for the weekend, they're not doing all sorts of things. So we are still likely to be successful as long as everybody follows the guidance.
Well, thank you for that clarification. I mean, it seems to me that there's clearly a mismatch between the government's public health advice and the message that's being put out by the Mayor of London and Transport for London. And I would urge you and your colleague at Public Health England to try and engage with the Mayor to see if we can resolve that, because the very strong message coming out of the London transport system is that you should not be on it unless you're a key worker, and that clearly is inconsistent with the advice that you're giving, is that if people can't work at home, they are still permitted to go to their place of work, even if they, so long as they can observe appropriate distancing once they get there. Can I also ask about the public health advice that people are permitted to exercise once a day? Now, many people aren't lucky enough to live around the corner from a park or have their own garden. So they will need, if they want to do this exercise in the air, they would want to get on public transport network or get in their car to go to somewhere where they could exercise. And my understanding is that in some places people are being discouraged from doing that, or indeed by the police. So again, it would be useful to have your clarification that if the advice is that people are allowed to exercise, albeit individually or with members of their household, then they should also be permitted to use public transport or drive a car to get to a suitable location to carry out that exercise.
So again, I'm going to take us back to principles around this. So I think, as you've highlighted, it's we cannot reasonably say everybody go into their garden, because we're absolutely well aware that a number of people will have no facility to go into a private space, and that is actually one reason why the exception, if you like, around exercise is there. Because if we're asking people to comply with this for all of our benefits, including theirs, we need to ensure that it is manageable and gives the impact to population health that we need. And people will be less inclined to do that if we have created rules which are simply not manageable. And if you are in a small flat in London with several small children and have no private space to go out to yourself, that is virtually an unmanageable task over a significant period of time. But then I think we also need to be clear what we mean by exercising. Walking along a street is exercise. Walking fast along the street is just as good as lycra-clad bicycling in the park. It's really good for you. So I think this isn't about having to go somewhere to do exercise. That's not what it's about. It's about giving people safe permission and opportunity for their mental and physical well-being, but importantly for the maintenance of this reduction in social interaction, giving them that opportunity to go out. So they do not generally need to be going off somewhere in a car or on a bus to something. In fact, we would prefer that they weren't, as you've said. That will imply that people are piling into vehicles in groups and heading off somewhere. Actually, what we want them to do is just take some exercise and some air safely at a distance, 2 meters apart, unless you are in a family group. So obviously, if you're a mum with a couple of toddlers, you need to hang on to your toddlers. I've been there, and take them down the street. But if it's strangers, if it's a different household unit, you need to keep apart, and ideally you do that on your own and at a distance. So I think some of these, I recognise it's important that people have the opportunity to ask questions and explain. And what I'm personally, and I know colleagues are trying to do, is explain the principles of this, because it is not possible to write into guidance every single permutation of a job or a family unit or a housing condition, which means that everybody can instantly identify a rule for them. So I think it's about taking fresh air and having the ability to go out and take some exercise. But ideally, we definitely do not want the scenes that we had last weekend of people accumulating in groups in parks. That's not what we want it for. That's quite dangerous.
And can I ask about the O70s and use of the transport system? The public health advice is that the O70s should self-isolate for the next 12 weeks and avoid going out altogether. But that, as far as I understand it, it's not now part of the law. It's not compulsory. It's advice only. So if a 70-year-old is fit and healthy and again feels the need to continue going to work, is are they breaking the law if they're on the train or get a car to go to work? My understanding is that they can still do that if they want to, and that the 12-week isolation period is just advisory. It's not a legal requirement.
So, these, if people are behaving in a way which impacts negatively on our risk, there's people around them or the populations, there is a legal framework behind that to prevent it. So currently, in the current pandemic, if people are accumulating, for example, in crowds in a park, that is a dangerous public health thing to do, and there is legislation sitting behind it and the capacity to ensure that that is discontinued. But I think just going back to what we call the vulnerable groups, I missed the first part, but just because the transmission on the phone wasn't quite so good. But I think what you were discussing were potentially two different things. So there are what I'm going to call a general vulnerable group, in whom we have identified that there is a risk potentially of having a more significant illness if they catch the virus. And then there is a very high risk vulnerable group, which I'm going to call the 12-week group, just for simplicity. Now, if I take that very high risk group, these are the individuals who will have been receiving texts and letters. They are quite, although it's a large group in numbers, it's quite a small proportion of the population. These are people who may well already know that they have a very high risk of perhaps contracting the infection or not being able to handle it well if they get it. So, for example, somebody who has recently had a transplant or somebody who is actively receiving chemotherapy for cancer, we know that their immune systems won't work. They will almost certainly have been advised already to ensure that they are not in environments that heighten. Now, those individuals, we say it's advisory that you should, for your own protection, stay right away from everybody else for 12 weeks. Don't go out on public transport. Don't go to the shop. Get people to help or get the system to help deliver your medicines. Let the health service know, because we can get you into different health systems a safe way if that's necessary. And if you have a private piece of ground or something which you can safely go to, which is 2 meters away from your neighbours, then that's okay. But don't otherwise go out. So this is a really vulnerable group. But for a 70-year-old, just by virtue of their age, is otherwise well, but may not handle the illness quite so well, what we're saying is take extra precautions, really work hard at reducing the number of social contacts you have. But I wouldn't suggest that they couldn't, for example, take their dog for a walk, but I would suggest they did it very carefully. They might go out when it's less busy. They will be very, very careful to keep a distance away. And ideally, if they don't feel the need to, they would not do that. So keep in as much as possible. And just on the compulsory bit, I mean, there is another side to this. If I was very elderly with terminal cancer with a limited life period, or I would actually want to spend time with my family, I might actually feel there was calculated risk and said, this time in my life, this is more important to me. And I understand that if I get the coronavirus, actually it might severely limit my life expectancy. And that's okay. And we have specifically said that for people who are nearing the end of their life, we recognise they may choose not strictly to that. And so it's important that that is not something which is so specific.
Thank you. Thanks very much. It is really helpful to get clarity, because particularly on the public transport issue, because I know in different parts of the country the experience is very different, and for those people who still want to travel in Newcastle, for example, the public transport is very quiet at the moment, and it is probably, safe to do so and keep social distancing. I think there is a big challenge in London with the numbers of people that still need to travel round and the capacity of the transport system, given a number of the drivers themselves or those running the transport system are having to self-isolate. I mean, what do you think is the optimum solution? Because we can't be asking people to self-isolate and then cramming people into public transport. We need to be able to keep that social distancing in the workplace and on the way there. So if we're not able to do that, surely the government needs to issue clearer advice that less people should be travelling.
So, yeah, I mean, as I said, I'm going to provide the scientific and medical element because that is my role rather than specifically a policy decision. But nevertheless, all of the government decisions have been based on the science and the evidence. And I think this is a question which arose at the press briefing yesterday with the Secretary of State for Health. And I think it is back to these principles, and it's both government and individual. This is actually not something, this pandemic is not something the government can solve actually. It can do everything it can to support people, service, but at the end of the day, this will not as to whether people do heed the reduction in social interactions. That is the bottom end of it. When it,
well,
sorry.
Could I just bring in the health minister there? Oh, actually, sorry, no, we haven't got a health minister. Okay, well, it's just because it can't be left to individuals to use their discretion, and I think that's how we got to the point where the government has had to become much clearer about the advice, because different people have different emergencies in their own lives. Those who are self-employed that can't otherwise support themselves feel they have to get on that public transport and go to work, even if they are not a key worker. So the lack of clarity is something that has to come into the science, because it can't be solved by individuals making these decisions for themselves.
Yeah, I would say it needs clear guidance, and I might just highlight the guidance that's there, but it also needs an individual interpretation, as you said, and in the example I just used about the very vulnerable people, because we all do have very different starting points for these and very different perceptions. I think what the government and the guidance, the advice that we give on the medical side, we try to consider where the balance of this is, but at the end of the day, we are putting out very, very strong advice now because of the point that we are in the epidemic curve, that people should adhere to this. It's dangerous for all of us if they do not. I think there's a short time frame for people to settle into new patterns. These are really big changes in lives we're asking people to make. And in fact, what we are seeing is there is increasing compliance as we go forward, which is good. So I think obviously we don't want the scenes that we had in the parks at the weekend. I think many of those have stopped, and we don't want crowding together on public transport, but that is the case in all parts of the country. And I think the more the message is going, the more compliance we are getting, and if we continue to get public, we will be successful in managing to pull down the epidemic peak, and we'll see that change in the use of public transport. I mean, the one thing I would say is I realise it won't be everybody, but there are always silver linings to these things, and if you're allowed out, if you like, one time in a day to do some exercise, suddenly it becomes very exciting rather than, so we could actually improve ourselves through this pandemic.
Okay, I'm going to bring in Selaine, who's got some questions about the NHS. You need to unmute. You're still on mute.
Unmute. Can you hear me now?
I can hear you.
Yeah.
Excellent, thank you. Obviously last night we heard the announcement of the Nightingale Hospital, and obviously there's been a lot of planning going into increasing capacity for the NHS. And I just wondered, I actually represent a very rural constituency myself with a very small hospital. What steps have been taken outside perhaps of the capital, where we've already seen what steps are being taken to ensure there's enough capacity for other cities, but also for rural populations?
Yeah, so all of the planning, there's a huge planning framework behind all of the work that we do, both now in this pandemic, but I think more importantly, sitting right behind it. So for example, I used to be a Director of Public Health in Norfolk, that has very, very rural populations. And there is always a pandemic framework sitting behind of mutual support across health, public health and other responding systems. So I think it's not possible. No country has hospitals in rural areas, for example, set up to deal with this sort of thing. It would be quite impractical. We are not unusual in this. We have high consequence infectious disease centres, and then we have a network of infectious disease units, and then we have a network of critical care and emergency care systems. So inevitably, if you're in a rural area, and I think none of us expect to have a critical care unit on our doorstep, but we do expect to, or we hope that there will be a capacity if we need it at some distance away. And the whole of the NHS planning is geared to ensure that the rural areas and the capacity for that population is planned for on geographical footprints. And the one thing I would say for this, and you would have heard in the news, I'm sure if you haven't experienced it yourself, but the Secretary of State also saying yesterday, it is really important. We do not want, for example, we saw the crowds in the park at the weekend. We do not want the crowds on the beaches either. And one of the key reasons for that is, the first one obviously is that they're too close together and they'll be transmitting infection. But then, so we're not doing social distancing. But the second point about it is, in general, rural areas plan for their population as it stands and have capacity for that. And then in some areas, like a seaside resort, they will plan for an increased upturn in some conditions during summer months. So you expect to have lots of families with cuts and bruises and broken ankles in the summer on a seaside resort, and you manage that and plan for it. You do not expect to have crowds turning up from London, for example, to Cumbria, and then requiring all sorts of acute care, which is why we are asking people to stay in the areas that they normally are, because that's how our planning system works.
Sort of following on from that slightly rural coastal theme, a sort of a question that I'm getting a lot from my locals. I think a lot of our tourists hopefully have now gone home and aren't coming to our beaches, but the people that live there all year round do have different behaviour patterns to those that we're being asked to change in the big cities. And a lot of people there perhaps go to the beach for a swim, drive to the beach and go surfing, drive and walk their dog on the beach. And we are coming up against resistance actually from the police that people shouldn't be driving to the beach or a large open area for exercise. And I just wondered what the health advice on that was, because for a lot of people, they see exercising in the sea is actually a very safe thing to be doing. And so just be clear to understand the guidance.
Well, so again, going back to first principles, obviously we're all in very different individual circumstances. So the virus itself doesn't last so well outside. So the outside environment generally is just on a pure viral transmission route on your own is probably a slightly safer route in general than somewhere with lots of hard surfaces where it can be harboured. But I think that there are two elements to this. One is, for want of a better phrase, we're all in it together. This pandemic will be managed because we all do the right thing to help all of us. And if we keep stepping out of line in different places or have exceptions, actually, that's a very, very difficult messaging. So I think most people are being really responsible. They're getting the message now, how serious it is. And I'm sure most people in rural areas and town areas are trying to do the right thing. So setting an example wherever we're living, I think, is a really important thing to do. Having said that, if in the same way that we're saying, if you live in a flat in London, you want to walk down the street because we recognise you need some exercise and you do so safely, we've said that is allowable. That is the balance on the mental and physical health elements and managing the risk of transmission. And so the equivalent might be, if you go to the seaside once in the morning when it's quiet, nobody's around, you're walking 2 meters away from everybody else and you have your swim and go back home and that's it, that probably is fine as well. So it's a different form of exercise in a different place, carried out just as safely, balancing the need to reduce the social interactions and transmission of the virus in the population, but also the needs of the individual to be able to stay in their house going forward and feel that's okay as well.
Thank you. And sort of leading on from that, we talked briefly about sort of tests and vaccine. Do you have any update on what progress has been made towards a vaccine and when that might be available?
So I think there's a tale of two parts here. So very, very early on, there was a huge call out to research, industry, and on the international front, and significant funding has gone in to support international development of potential new vaccines, and that is under exploration now. That's the positive bit. The other side to it is, despite most of the sort of stories you will hear every now and again, I mean, a vaccine would be just perfect, because if we had one and we knew it worked and we knew it was safe, a critical point, then we could deploy it, and that would be a great way to end a pandemic. The reality is to develop and then safely test and use a vaccine is absolute minimum about 12 months, more likely 18 to 24. And in this particular circumstance, when it was Ebola, for example, in West Africa, some vaccine was used quite early on, but the mortality rate in that outbreak was somewhere around 60 to 70%. So on average, if you got the disease, you were far more likely to die than not. Now, for this disease, it's difficult because so many people are becoming infected, because it's completely new to us. But on an individual basis, overall the population, 99% of us will get better. And so that balance of risk in testing a new vaccine and using it is in a completely different sort of sphere. And so we have to be really sure that when we have a vaccine, if we have one, that when we use it safely, and we're not creating more harm in doing that than good. So quite a long way.
Thank you. I don't have any other questions. Thank you, Catherine.
So I was going to bring Stephen in next to, who's going to ask about the self-employed. Oh, hello.
Thank you. Yes, I'm not muted, am I? A couple of questions, I think, for Justin largely. The biggest petition here was the one signed by 600,000 people, calling for statutory sick pay to be extended to self-employed people. I wonder, Justin, if you're able to comment on whether that's been considered as a possibility for this package of support for self-employed people that we're now expecting to hear about tomorrow.
I mean, I'm not Treasury, so I can only try and make educated guesses. I'd be surprised, because statutory sick pay is a minimum requirement that employers can pay to employees. And so if you're self-employed, you in effect can't pay yourself. So I would be surprised if that was one of the announcements. I think there will be significant additional announcements to support people who are self-employed. And I think we've all seen the requests in our individual sort of inboxes. But on the wider point of statutory sick pay, I do welcome the fact that that's now available from day one. And we made that decision very quickly. And also that we extended it not just to those who were actually sick and away from work, but those who, following government guidance, were then self-isolating. And we also made it that for any business under 250 employees, they could then reclaim the money up to 14 days for any employees who were then eligible for statutory sick pay. I must also stress that is the minimum legal requirement, and from surveys done, it's around about 68% of employees actually get more than the statutory sick pay. In many cases, they will just carry on getting paid as normal, depending on those business circumstances. So that is the minimum requirement that a business can pay.
There's quite a head of steam behind the argument that statutory sick pay should be paid at a higher rate, just £94 a week at the moment. A minister attracted a good deal of attention the other day by saying he couldn't live on £94 a week. Is that something that's being looked at, the possibility of increasing the rate at which it's paid?
I think part of the cause of that, and yeah, I did the opposition day debate on this, was some members drew comparisons to other countries, but to an extent it is comparing apples and pears, because underlying this we have our welfare system, And the statutory sick pay is the minimum legal requirement that employers would have to pay. But depending on individual circumstances, they could also, in addition to statutory sick pay, be eligible for welfare support. So it does depend on individual circumstances, and that can then, depending, the rate of that would then depend on, do they have children, dependents, their housing costs, etc., etc. So it can't just be taken in isolation. That if you are on low income, you wouldn't just be left with the £94 if you are eligible for additional support through the welfare system. So we have a more joined up approach, a more comprehensive welfare net, but it is based on individual circumstances. If either of us two were to find ourselves on statutory sick pay because of the earnings that we have and things, we wouldn't then be eligible for that additional support. But the people in genuine need, that's what we do. We target the support, and I welcome. And I know there's going to be more announcements. You know, we're seeing this on a daily basis. There's already been about £6.5 billion of additional support during this temporary period that DWP is distributing to those most in need in society. And I, like everybody else, will welcome further announcements for self-employed people that we expect in the coming days.
We'd love to ask you what might be in that package, but I'll resist that temptation.
I'd love to be able to tell you.
But would you accept that it'll need to address kind of lots of freelancers, for example? But there's also a worry about people on 0 hours contracts who probably aren't going to benefit from the 80% wage subsidy offer, but will need support of some kind if they have to self-isolate, if they have to give up their work for any reason.
Okay, so yeah, so specifically around the individual 0 hour contract. So we've made a couple of changes already. So in terms of their eligibility to various different things, you will look at the average earnings over an 8-week period, not just in the 1 week where perhaps those hours have been reduced as due to the impact of the virus. It is over an 8-week period. But actually bearing in mind...
Is that universal credit?
Yes, that would be with universal credit. But bearing in mind with 0 hour contracts, your income then is taken into account as part of that welfare net. So if for whatever reason an employer wasn't doing what we would hope they would do, and I do recognise there are times to challenge employers, and there are some employers that have been highlighted by the media who haven't been acting in, I think, the spirit we'd all expect them to. But there will also be some businesses having to make very difficult decisions because their cash flow has been impacted so much. That is then where the welfare net would then pick in. Many of those people on 0 hour contracts will already be in the system, and if not, then they will be able to then register for the UC system straight away.
I think it is very likely, whatever is said tomorrow, that universal credit is going to be carrying quite a big part of the load of supporting people over the next few weeks. We've seen this 500,000 applications, I think, new applications in the last week for universal credit. The Secretary of State was at the Work and Pensions Select Committee this morning talking about that. Is there a chance here to look at some of the problems with universal credit? You know, there's, I think, a really big problem about the fact you have to wait 5 weeks after applying for your first regular benefit payment. I think it's going to be terribly difficult if we're saying to employed people that your 80% wage subsidy kicks in straight away, but self-employed people, you've got to wait 5 weeks before your first regular payment. And another issue that's been raised about universal credit, particularly if it does have to support more formally self-employed people, is that it stops at the moment once you've got £16,000 in savings. And you know, there'll be lots of self-employed people who are not well off, but do have more than 6,000 and perhaps more than 16,000 in savings, and I think we'd all want to see universal credit supporting them properly, which it won't do if those caps stay in place.
Yeah. Well, I'm now straying very much into the Minister for Welfare delivery territory on universal credit, but I'll answer broadly on behalf of the DWP. Anybody who applies for universal credit can get support straight away through the advance payments. What that in effect means is you would get 13 payments over the year rather than 12 payments over the year. So anybody in immediate need can access that. We've obviously removed the need to have a face-to-face conversation about accessing advanced loans as part of the minimising direct contact with individuals. You are right to talk about those numbers. We processed a record 105,000 in the last 24 hours. It's just over 500,000 in the last 9 days. We anecdotally suspect a proportion of that will be self-employed people who perhaps, and I don't know what the details will be when they are announced, but when they are announced soon, maybe that UC isn't then actually the area of support they will need to do. But at the moment, that is the advice, that if they don't have direct income, then use the welfare system, which obviously is predominantly universal credit, but for some of them it could be the new style ESA if they've made the right amount of contributions through the national insurance system. So you know, it's a moving brief. We fed in. We all support. You know, I'm encouraged as an individual MP that by and large this is being done on a cross-party package. I don't envy the Chancellor finding the most effective way to target the support for self-employed people. Everybody agrees we've got to do it. How you do it, it's a lot more complicated than the 80% minimum support provided to people on PAYE, where it's very black and white how much people earn. Then in terms of the point about the 16,000, so the welfare net is there to target support at the most vulnerable in society. Normal rules dictate that if you've got, remember it's a household benefit, so if you have somebody who's earning you know, different levels of money, and then also with that £16,000 that's there, then those wouldn't be eligible at that time. But obviously, as circumstances change, then they can then enter into the system when they are in that point that's deemed to be of most need. I don't think that will change, is my view, the 16,000. Okay. I could be wrong, as I said, I'm not party to the advance notice from the Treasury, but I'd be surprised if that's where they were doing it, because they will want to target the money at those most in need at that particular point.
A final point, Catherine, if I think it does all depend how much universal credit is expected to support a large number of self-employed people over the next few weeks. But that's a different job from the job of supporting the most vulnerable, which universal credit has been designed for. Can I just ask you, your point about you can get an advance, that means you'll get 13 payments over 12 months. I didn't quite understand. I mean, the problem is, of course, that your advance, you have to pay it back in the subsequent payments, and therefore that reduces the amount that you receive subsequently. And that does, as you know, something that a number of us feel quite strongly about. That does mean, I think, that universal credit for many people is a pretty unattractive offer as things stand.
Okay, so the easiest way to explain this is over a 12-month period, whether you have an advance payment or don't have an advance payment, you will be given the same amount of money on your individual circumstances. If you choose to have an advance payment, you'll have that first payment day one or at any point during the 5-week wait that you need it and request it. And that will then reduce your following 12 payments. But at the end of the 12-month cycle, you would have had exactly the same money. So if you were entitled to £5,000 support over the year, for example, you will have £5,000 at the end of the 12-month period, but it would have been paid in 13 payments. Your first payment would have been sooner. Your following 12 payments would have been a little bit less. But at the end of that 12-month cycle, you would have got to £5,000. You choose to not take the advance payment, and many choose not to, then you will still get £5,000 at the end of the year, but you will wait for your first payment. That's the easiest way to explain it. And that's why we say it's not a loan, it's an advance payment. It's your money, which is giving you advance access to that as part of your money that you're entitled to over a 12-month period. Now, moving forward, that's obviously, as you know, will be extended to 16 months. And then again, if I remember rightly, that's been extended again, but that's some way off before that's implemented. We've also, you know, strengthened the bits about hardship payments. There's £500 million has been given to local authorities, so that again, targeting the support at the most vulnerable, the people who need it straight away. There's more discretion in the system that we can deliver locally. I personally support that. Whenever we sort of bid for money to Treasury as a department and we have to decide which of the bits to do, I'm a big supporter of, where possible, providing discretionary money at local areas. Maybe I'm a bit biased because I spent 10 years as a councillor in Swindon before I became the North Swindon MP. But I do think we all represent very, very different areas, rural, urban, different types of employment challenges. And therefore, wherever possible, devolving discretionary funding to support vulnerable people, I'm a big supporter of. But that's me speaking as an individual rather than necessarily the corporate line.
Thank you,
Catherine,
Stephen.
very much.
Thank you. And I think Stephen raised the point that there are two challenges here. One, supporting the vulnerable. The other, supporting the effort, which is to stop the spread of the virus. And I think there isn't, and I know that hopefully this will be resolved tomorrow when further measures are announced to support self-employed people. But at the moment, far too many people are being put in the position of not being able to do what they would like to in terms of not spreading the virus, because they will be left in too much financial hardship if they do not go to work, which is why the public transport in London is still very busy, which is why too many people are still going out to work, even though they would rather stay at home for the safety of them and their families. Is that a concern that you share?
Well, we all want to get the support for self-employed people brought forward as quickly as possible. To be fair to Treasury, they have already made very helpful announcements around the deferral of self-assessment payments, made very clear that HMRC will be very sympathetic with people who are due to make payments or need to change their arrangements. Some self-employed people and businesses will be eligible for the grants, the loans that have been put into place. Many local authorities, through the additional money they've been given, are also putting additional packages in place. But I think we all agree, as quickly as possible, that Treasury can get the additional support into place. I have every sympathy with the Chancellor on this, because it's so complex. I ran my own business for 10 years. To be able to, at any point in that 10 years, tell you accurately what my earnings are or aren't going to be in the coming days in normal times was nigh on impossible. They've got to find a way. I know they're working at pace. I know all of the business organisations, your FSBs and CBI, they're all feeding in. We're all feeding in with the suggestions that we're getting. It's complex. It will make a big difference, I think, when that's confirmed, because people have to make decisions about how they're going to have the money to carry on. In the short term, universal credit is an option, and we're working at pace. As I said, we processed 105,000 claims alone in the last 24 hours. We will keep doing our bit, but I suspect once those announcements are made, some of the traffic coming towards universal credit will probably move and look at the other forms that will be announced.
Okay, thank you. I was going to bring Catherine in now, give you a bit of a break, Justin, because Catherine's going to ask about education, I think.
Greetings. So another one, similarly to Stephen, which got to the 600,000 signatures mark, was about a petition for schools to close. And what that figure tells you is that British public and parents especially were really concerned in the early stages about the infection risk that schools presented, but also about keeping their family and children safe. I would be really interested if we can just understand the thinking for the timing of the school's closure announcement. Is it because the British public wants them closed, or is it more to do with the medical advice? It's possibly, I can't quite, I'm sorry, Dr. Harries, who's doing a wonderful job. I wonder if she can help understand that position.
That was led by advice from the scientific advisory group from emergency CMO, the Deputy CMO, and so on. It's purely based on the science as we move from the contain phase into the delay phase. So it's a closure of all schools, but of course we want the schools also to be open for the most vulnerable children, and also the children of critical workers, unless of course they can't do that work from home, which is our preference, so that they can look after their children at home if they have children. Can you hear me?
Understood. Yes, thank you. Yeah, okay. So the medical advice was very much what was driving the school's closure day. Got lots of questions asked about exams, so perhaps because the you could talk through the petitioners' concerns about exams and exam grades, especially for those key transition stages into those who want to go into the technical college or further education at university.
Yeah, so all exams, no exams will be held in schools. We considered that decision very carefully. We looked at all the options, and there was an option of saying, well, let's year 11s come in and take their exams and then go away again and put the desks 2 meters apart, and the same for year 13s. But there were a whole host of reasons why that would not be fair. For example, if large numbers of students opted for the alternative, which I'll come to in a second, and some went for the exam. So in the end, we took the decision, I think it is the right decision, that there will be no exams, either at secondary, and no tests, no SATs at the end of primary schools, which means also there will be no performance tables this year, either of GCSEs and A-levels, nor of SATs in primary schools. So what's happening as an alternative, we're working with Ofqual and the exam boards to publish detailed guidance about what will happen. But in broad terms, it will be the grades for A-levels and GCSEs will be based on teacher assessment, which itself will be based on the work of children over the 2 years of the course, on mock results and predicted grades. It'll also be based on the prior attainments of pupils at a particular school, and of course the progress that pupils at that school have made in previous years. Because we want this system to be fair, or as fair as possible, not just between pupils of this current academic year, but of course between pupils of previous academic years and subsequent academic years, because these are children of roughly the same age, and they will be competing in the future for the same jobs. So we need to make sure that all those years are comparable. And the work that has been carried out so far by Ofqual and the exam boards, I think, is very rigorous, and it is the best possible sort of facsimile of real grades. And the grades that are awarded to candidates this year will be as valid as grades awarded to candidates who actually took the exam.
Wonderful, thank you. Another question that petitioners are raising is just of understanding what measures are in place to support more vulnerable children in schools, those in receipt of free school meals, but also what measures are in place to make sure that the teaching staff and teaching assistants that are in schools at the moment looking after children that they're safe as well.
So the definition of vulnerable children for this purpose is children that are either have an EHCP plan, an Education, Health and Care plan, or they are being supported by a social worker. It is not the general population of children eligible for free school meals, which is a significantly larger group of people, of young people. And for those young people, there are measures in place for schools to provide vouchers to those children, and we are also in the process of creating a national voucher scheme. But at the moment, many schools are issuing vouchers to their free school meal children to use in the local Tesco's, the local supermarkets, and also on some occasions providing food packages to those young people. The very vulnerable, those who have the support of a social worker or have an EHCP plan, we are encouraging to come into school, because for those children, the safest place for them may well be the school. Now, some families will say, no, they're actually safer at home with us. They're on the EHCP plan, but we believe that they are safer at home, and that is a valid decision. Where children are being supported by a social worker, and there is a difference of opinion about where they are, where they should be, where they will be more safely looked after, then that will be discussed between the school, the parents, and the social worker, and those discussions are happening. But it is important that we do everything we can. It is a priority of the government to make sure that the most vulnerable children are safe during this crisis.
And the teaching staff and teaching assistants?
Teaching staff, yes, sorry,
yes.
Yeah. So there are significantly fewer pupils attending school as a consequence of the messaging that is that we want children to not to come to school unless they're in those categories. because they should be at home, and that's the best way to save lives and protect the NHS. We have issued last night some guidance about social distancing within the school. So we want teachers to be at least 2 meters away from their class, from the desks, to be at least 2 meters away from each other. So both the pupils are protected through the social distancing, and also the teachers, the staff, are also protected. And that's what that guidance sets out. And we'll be issuing more guidance in addition to the guidance we issued last night, giving more details on a sector-specific basis.
Understood. And I'm not sure whether this is one for you, Nick, or whether it's for Dr. Harries, but can we give parents any timescales at all about how long the schools are going to be closed?
No, that is absolutely a scientific, I'm not even sure whether Dr. Harries will be able to answer that question either, but it is absolutely based on the science. We are, in terms of our policy in the Department for Education, it is led wholly by the scientific advice.
Understood. Dr. Harries?
No, I'm unmuted.
No, you're perfect.
Oh, right. Yes, just to comment on that. I mean, I think a really important thing is there is a perception of the risk of a school, and if schools were dangerous places for disease transmission early on, that would have been at the top of our list to close them. I think, again, it's a difficult concept to get across, but the reason the advice was to close them at the point that it was to do with the rate of rise in our epidemic curve and the fact that it is another opportunity for social interaction, if you like, but it's not because it's some sort of hotbed of transmission. And I think that's an important thing. If it was, those children would not have been there, and it would have been our first point of advice to close. But what our modelling did show was that it made a little bit of difference. It adds on an additional benefit in terms of overall reduction, so that's why it was brought in. But equally, our modelling suggests that you need to do it for quite a significant length of time, which is why we have not been keen to try and promote something with a very small impact very early on, only when it's absolutely necessary. So, yeah, exactly right. I can't actually give you the precise date either, but certainly what I can assure you is, as we watch the curve and we watch the epidemiology of the cases around the country over time, then we will be looking to try and manage that the rise to make sure it's safe for the whole population, but certainly not keep children out of school any longer than we need to.
Understood, thank you. And then just a final one. So there was a tweet yesterday from a comedian that said he was considering expulsions from his home school on day one. Can we reassure the parents and petitioners that you know, there is additional support and help coming, because they can't hope to take over from the teaching profession at these times, but are we going to support them to do as much as we can?
Yes, a lot of schools, all schools are giving children work, either through worksheets and so on, or through the internet. And we are currently working with BBC to see how much help they can give in order to put lessons onto television. But also there are a huge number of private companies that do provide educational material online, and we are about to produce some quite detailed guidance for schools about how to navigate that particularly complex marketplace of provision.
Thank you very much. Thank you, Chair.
Thanks very much, Catherine. And could I just say, as a mother of three myself, who is juggling working from home and with children, what an amazing job our teachers do. How grateful we all will be for them when the children can go back to school. But also thank you to the schools for all the hard work they put in to providing packs and information so that we can do our best to socially isolate during this period. I just wanted to put that on record. But the other question I had, and it might be a scientific one, and it comes down to the personal protective equipment issue that I know you mentioned, Jenny, that is getting distributed by the army now, but we do hear far too many reports from NHS that still don't have, and there are also many other frontline workers where the public are concerned that, you know, should they have protective clothing as well? And it comes down to this issue of viral load and whether those who are more exposed to perhaps even those that are carrying the virus but may not be showing symptoms, whether they are more at risk and whether we should be doing more in terms of protecting all our workers on the front line from that exposure to the virus. Is there something that you can explain to us about that and give us some reassurance on that front? You're still on mute, sorry. There.
I think it comes unmuted after a while. I'm too quick, I think. So just, yes, I am very acutely aware of the number of different services, frontline responders, not just healthcare sector. So, for example, I personally try and join a police chief call on a weekly or twice weekly basis, because I'm very aware of this, things like staff or home office, prison handling, that sort of thing. Each of those sectors has had some guidance on personal protective equipment. I think there is probably still some noise in the system for two reasons. One is around people's perception of what they need, and one is about an understanding of what that PPE does or doesn't do. And both of those, I think we have done a lot of work to address, but we are actually continuing to do so. So for example, the care sector, so this isn't just a residential care unit, actually it's about people, probably 3 or 4 different people going into an elderly person's home to in very close contact and supporting them on daily living, bathing, washing, all sorts of things. So we have issued guidance on that, and for most people you do not need a significant amount of PPE. So if the individual you're caring for is well and is asymptomatic, you wouldn't normally be requiring any PPE. What I am very passionate about personally, and colleagues know this, is that this is a risk-based assessment. So it doesn't matter where you are, whether you're a policeman or in an ambulance or wherever it might be, there has to be a strong rationale for what we propose in terms of what your risk exposure is. And that is what the basis of all of our guidance is. There's been a lot of noise, I think, recently in the media around suggesting that our guidance differs from the World Health Organization guidance. Actually, is not really the case. We currently have a higher specification for some of our masks, our FFP3 masks. And we have different approaches to the gowns and aprons that we use because of the underlying way that in the health service we have tackled antimicrobial and infection control. So there is usually a very strong rationale behind this, but I think what we are working on now and will help is getting a simple message. Public Health England, who does much of the guide, has just revised some infographics to try and make that simpler to translate through, particularly to our health service staff. And we're looking across at each of the different sectors to try and ensure that we can get the same clear communication out to them.
Okay, and Kerry, are you happy to come in now to ask your questions? I think you wanted to touch on long-term health problems and also financial hardship. Oh, hello, we can't actually hear you, Kerry, but you're not on mute. So I'm not sure whether your technology is not working. You might need to plug yourself in, or you're on a laptop. Have you got headphones? Shall I go? I'll go to Martin and come back, see if you might need some headphones to plug in maybe. Martin, are you happy to come in now on your questions?
Yeah, happy. I'm just wondering if I could perhaps follow up on the one you just asked about PPE, just to ask what assurances we can have that the country will have enough PPE equipment for the essential workers that do need it, because I know that's a question that people have been contacting myself about.
Yeah, so I think there are different things. So one is people understanding what it is needed and what the guidance is. The second one is, have we got it? And the third one is it in the right places when people need it? So at the moment, currently, we have sufficient PPE across the country to manage all our needs. And part of that reason for that is because actually we have what we call the pandemic flu stockpile. So we have always had a plan in the country for managing a pandemic of a respiratory virus, and we have pulled heavily on that as our cases numbers have risen, and that is part of our long-term planning. So that's a really good part of the resilience across the UK. There were some issues. The way the PPE was ordered and distributed, or is normally in a routine basis, is, if I just sort of describe it, a hospital, for example, would routinely order PPE a bit in the same way. It might order its stationery or its paper clips, and it just got supplied. Now, of course, when you have an unprecedented event like this, and you suddenly have a very steep rise in demands, that system needs to be a much more refined system in order to make sure that the essential PPE gets to the right place at the right time. So I think we've acknowledged that in that very rapid rise, there were a few misconnects, if you like, in terms of where it was arriving at what time, and that was both in numbers to hospital trusts, but equally out to some of the other sectors that we've just talked about, so care sector, for example. But over the last few days, well, weeks actually, we have revised that completely. There is a special section set up to take all of that PPE ordering and distribution completely out of any other framework for ordering. It's linked up with the Army logistics distribution, and those deliveries have been going on through the night. In fact, I know hospital trusts have been warned to say you'll definitely get it, but don't be surprised if it arrives in the night. And that's in order to ensure that it arrives to the right place at the right time. I know there were some final deliveries, for example, going into the care sector today, which will have finished a one-off distribution, and there have been letters out to all of the acute trusts and all of the care sector cascaded from the Minister for Care. So I think that is in a much better place. Where we go forward, I think one is, as I referred to earlier, is just about getting a shared understanding, particularly actually with my medical colleagues, about what the underlying risks and appropriate PPE is, and we will be working on that with the CMO and with the different Royal Medical Colleges. But equally, as we go forward, we do have to recognise that the whole world is pulling on PPE supplies, and we're in a really good position. But much of our PPE stock comes from China, and clearly a lot of the Chinese facilities have been out of action or are just coming back into action. The government has worked really hard to secure all available stock. Very early on in the instance. I know it won't be evident, I recognise, to colleagues and to the public, but it has been a huge process of work, and I can assure you that's continuing. But we will be needing to look, and we have a group established now to be checking the use of the PPE against the epidemiology and against what we have available. So it's a big piece of work, but I think frontline staff should be feeling that that has improved now.
Can you Mark, just look yours down now. You're not muted, but we can't hear you. Don't know what's happened. You've caught it off Kerry.
I've muted and unmuted. Is that any better?
Yeah.
What I was saying was, I'm aware that there are a number of manufacturers of PPE equipment in the UK who are exporting product just now. If we got to a dire situation, would we be taking steps to stop anything leaving the country if we needed it ourselves?
Yeah, I mean, I'm probably not in a personal position to comment on all the individual suppliers, but I am very aware that there's been a call to arms, if you like, to all the suppliers, and looking to see whether individual manufacturers of items in this country can actually switch to products for PPE in the same way that there has been, if you like, for respirators and things. And there's a lot of very positive discussion ongoing. So all of those avenues have been and are continuing to be explored.
Martin, you've gone quiet again.
Okay, hello?
Yes,
Okay.
Thank you.
The questions I was coming on to were about communication and the information going out. And I just say at the start, I thought the text message that went to just about everybody I know was a brilliant stroke, although I was a little self-conscious about clicking on the link. But brilliant idea, I think, to do. But how are we making sure that messages get out to everybody? Not everyone has a smartphone or access to the internet.
No, so that's why we've had multimedia channels. So you will have seen, just kicked off yesterday was a brand new, stepped up with the new advice, TV advert, which features the Chief Medical Officer. We're using social media influencers, so that will pick up many of the younger people. It's out in print media as well, and so for example, we've also tried a number of different routes, and we're very cognizant that a number of the probably the majority of our most vulnerable individuals will not be those who use smart technology. This is always a communication issue. So for example, where we have identified by digital routes the 900,000 in the very high risk vulnerable group, we know we have surprisingly, we have electronic communication reach for about 70% of those have used it. In the same way that if you've had a text message for this, they will have had a text message about their vulnerable condition. But equally, the mainstay of that is through letters. And obviously, many of these individuals will be communicating with their own GPs. So we're doing a little bit of overkill in a way, I think, but for the very good reason that we want to make sure that those people who need to understand what the risks are fully informed.
Can't hear you. Martin, we can't hear you. There we can. No? No. Martin, you're now muted on the, there you go.
Yep.
Yep, there you go.
Yep. I've certainly seen a number of the broadcasts from the press conferences with signers. Do we have all of them being now signed, and is it reaching the people with learning difficulties as well?
Yes, I would have to get back to you to check on this, on the number of conferences that are signed. I'm sorry, I don't have that, but very happy to provide that. I do know, though, that some of the other communications, so for example, we have different guidance for people with learning disabilities, for example. So it has very simple graded messaging, which is checked externally, and then a picture to try and get across to individuals the importance of this, but also without frightening them and being very attentive to how they might perceive this risk. And then running alongside that, there is guidance for parents and for carers of individuals, particularly children who have learning disabilities or who have, for example, autism, so that they understand the sorts of triggers and reactions that children might have, not just in verbal terms, but actually the sort of physical reaction they might have if they become particularly frightened, and then some links to support systems to help them help their child through this time. Because for many, as an adult, it's an unusual event. If you see the media broadcast, we want people to be aware and take action, but equally we do not want to be frightening people, because that tends to move them into a position where they're not taking sensible actions. So it's a difficult balance, but we hope we have tried to think of all those different avenues. But certainly I will I'll ask our communications teams about the signing.
Thank you. Are you finished, Martin? Are you finished now, Martin? Thank you very much. So I just had a couple of questions that haven't managed to get covered, either for technological reasons or because they've just appeared in the news. One is about the new test that has been mentioned will be available as early as next week. This is a question probably for you, Jenny. The 15-minute home test and I presume this is the antibodies test. Could you give us an update on what that test is, when it's likely to be available, and what impact it's going to have?
Yeah, so there are a number of moving channels on the tests. So without seeing the particular reference, it's difficult. But I'll give you. There are two things which are in a very near development phase, if you like. So one is the antigen test. So that is the here and now test, the one I referred to earlier, which is likely to be a drive-through. Let's call them the drive-through and the pregnancy test, just for simplicity. So the drive-through, have I got it here and now test, is being evaluated at the moment. Obviously, we need to be cautious about how quickly that can expand because of, again, all of these tests need supplies and reagents and various other things. But that is currently being evaluated, and that one will be very helpful in helping our health and care staff understand whether they need to be off work or not and keeping that system going. There is an antibody test, and there are two elements to that, if you like. That is to say, have you had it, which equally is very good for our health and care staff, but it would be more like a sort of pregnancy test, do it at home. But that is still very much early in development, and I think the Secretary of State referenced yesterday that the UK had bought a significant number of tests, but we do need, before it is launched out in the public, for obvious reasons, we need to be sure that it is properly evaluated against our own gold standards that Public Health England run, and that is an important first step. What we do not want is to find that we're using a test which doesn't help inform us, and it is quite likely that if, suppose a healthcare worker, for example, had that test, it would be really helpful, because then we would know, if it was me, say, I would know I had the illness, I was very unlikely to get it again in a short term, and I could safely be working on the wards. And equally, actually, I may be less worried about what PPE I was wearing, because if I've had the disease, it's not so important whether I have exposure to it. So, I mean, those are quite difficult things to keep there, but I think that one we do need to check. So we've bought into the testing and the theory, but we do need, before it's rolled out widely, to make sure it's right. And I think if somebody had a positive test on that, certainly on an initial basis, we will be wanting to do a serology test, a blood test as well, to check that the two tie up. Over time, why that's going to be really important is, one is because of our health and care staff and our frontline responders, knowing that they're safe to be working on the front line and that they've had it. But the second one is that this one about understanding the spread of the disease in the country. So although the WHO message has been test, 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 that messaging is, or WHO messaging is going out to every country across the world. So much of that is focused at lower and middle income countries where they may not know they have a problem yet, and their infrastructure for infectious disease is not as solid as it is here. What we have done is had a controlled movement, if you like, from the early containment phase where we did test, 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 to a movement where we are managing through delay and into mitigation the important clinical patients that we need to manage. There is no point in sending out clinical staff that we need on the front line to test people in their homes where it's going to make no difference to our management. So this is a sensible and proportionate testing process. But that antibody test in due course will allow us to understand how the disease is across the country. For example, it will give us more information about children, whether many of them have had the disease and have had very mild symptoms, and to understand the pattern of disease. And we'll be able to do that through genomics as well. So very important looking forward, and very important managing the tail end of the outbreak.
Yeah, and could I just say though that I absolutely agree with everything that you've said. I think what the public find difficult to understand and to have full confidence in is how you even know now how many people may or may not have the symptoms, because you're not even supposed to phone 111 unless you cannot cope with your own symptoms. So really the only measure you have of how far the virus has spread is how many people are hospitalized. And in reality, the only real figure we have, and the one that's published every day, which is really awful, but it's the figure that we have, is the death rate. But the death rate is only really a measure of how far our health system is able to treat these people and how many ventilators we have. So could you just explain that? Because I know that's a big concern for the public. We may get some nasty shocks because we don't actually know how many people there are who have the symptoms.
Okay, so just on that last point though, I do just want to come back on that. So the death rate is, we currently have full capacity to manage people coming through the health service. So there isn't a vaccine and there aren't specific treatments, although we are looking at some potential treatments and have done right from the start of the outbreak. And there are trials planned to make sure that we can use anything which looks to have, safely used, to have a positive outcome. But so where people are very sadly passing away from coronavirus now, this is not because of the lack of facilities in the NHS. It is because they have a disease which they have succumbed to despite the best efforts and despite the facilities in the NHS. We will never be able to save everybody from this, in the same way that even though we have antibiotics for pneumonias currently, people die from pneumonia. So just really important people don't think that our current deaths are in any way linked to a lack of capacity in the NHS. It is simply because all of the treatments have been applied, and very sadly that individual has passed away. So I think that's one thing. But your point on the testing and the numbers is an important one, because I don't think we are saying that we know every case. And in fact, we've said quite the opposite. We have said that we are very sure there are more cases, far more cases, thousands more cases, if you like, out in the community. The important thing at this point is most individuals get better, and we're pretty confident for a number of different epidemiological reasons that the 1% figure on the infection fatality rate, so the number of people who are dying from those that have it, is right. So what we can do is, it's much easier to see how many people have died than it is to count right across. And we could spend huge amounts of time looking for people with very mild symptoms, and we're not going to treat them any differently. We want to focus on our health service. So when we get the antibody tests on in due course, this time next year, I'm sure we'll have great data. At the moment, we are counting what we are counting, and we're not suggesting we're counting every individual mild case. But we are still very confident on our current epidemiology that the 1% is right. Very sadly, of course, that is the figure which comes onto people's screens. And it's really important that we manage that everybody takes the right actions, does the social distancing, so that that 1% represents people who we could not have helped in any way. Not that we have managed to get such a big rise in our health system that those and other people are not able to be helped.
That's really helpful to understand. Thank you. I think Catherine wants to come in on this subject as well.
Yeah, thank you very much, Chair. So I'm wearing two hats today because I'm also a member of the Science and Technology Select Committee, and there was some very interesting new news on testing kits from Public Health England this morning, and the professor very kindly outlined the fact that, you know, volumes of tests, antibody tests, so the test that says, have you had it, are being ordered in the millions. There's a protocol where they want to just check that they're working. And then she was talking about, you know, days, not months, in terms of being able to roll those out as a priority to NHS workers. And I was just wondering if you had any update, or whether it's PHE leading on the rollout of those tests, because I think that's a game changer for the public perception.
So we're both talking about the same thing, in fact. So the 3.5 million, which the Secretary of State mentioned yesterday, and I'm guessing it was Sharon Peacock who was talking at the site. There we are. So that probably is good evidence that we are all entirely joined up. And in fact, Sharon is one of the key clinical professionals. So we have a clinical group which is chaired by the CMO, includes all of the UK CMOs across the different devolved administrations, myself, my DCMO colleague, and then colleagues from PHE, Public Health England, and NHS England and NHS Digital. So all of this is joined up. we're working on it. So it's the same testing that I'm talking about that you're describing and the Secretary of State has announced, and it will be a game changer. As I say, my only caution, which sounds like she was doing the same thing, is
it's got to work.
We don't want to roll out something which we can't say works. We are all very excited to be doing this, and we absolutely recognise the importance of it in relation to our health staff. And we know, we're one of them. She and I are both doctors. We want to know, in the same way they do, are we safe? Can we be managing patients safely? And actually, it significantly affects our planning and our understanding of the resilience of the NHS, because if it turns out that a large number of us have had it, it means that we don't have to be quite so anxious about, for example, workforce absences going forward, and that adds to our confidence in the resilience and our management of the peak.
Thank you. Thank you so much. Thank you. Unless anybody has any final questions they want to ask, in which case wave your hand. I will let our three witnesses go, because I know how incredibly busy you are working on behalf of the government and the public to deliver on the things that we know the petitioners are very concerned about. So I thank you very much for your time today and the thoroughness of your responses, and we very much look forward tomorrow to receiving an update on the situation for self-employed people, because that is a huge concern for a huge number of petitioners. And I just wanted to end as well by saying that we know that Parliament is going into recess, but the petitions don't stop, and the concerns of the petitioners don't stop. So I do hope that in this new world of technology, and hopefully our trial today will be considered a success, and we will hopefully be able to get a transcript of it and be able to circulate the responses, but that we will be able to continue this dialogue and find ways to be able to provide petitioners with answers to their questions, even if we can't do it in the usual way that we have done today in Parliament. And hopefully it will not only add to the public debate, but will add to the strength of our democracy and democratic engagement as well. So thank you very much indeed, very much to all of the committee members that contributed today, and to our three, to you, Justine, Nick and Jenny as well. Thank you very much.